Hello, everyone, and welcome back to the podcast. Today, we have a very special guest with us, Dr. Nadia Salvo from Dorothy Ley Hospice. She is a palliative care physician and works both in a chronic pain clinic as well as a long-term care home. Welcome to the show.
Thank you.
Actually, I think I'd like to begin by first thanking you for offering time for the podcast today. We hear a lot in the news about the raw numbers associated with the pandemic, but rarely do we get to hear an individual's real experiences working on the front line. So I truly appreciate you coming as the first guest to the Stories from the Frontline podcast series. So I think we could begin by, if you don't mind, could you describe what you actually do as a palliative care physician?
Sure. Sorry, excuse me. So as a palliative care physician, that's part of my job. I largely work in the community. So I see people who are living with a terminal illness, usually anywhere from their last days to weeks of life upwards to their last years of life. And I see them in their homes for the most part. I also work in the hospital, also doing palliative care. So oftentimes patients will be admitted with life-limiting illnesses and they need symptomatic management, or sometimes they will be in the hospital for the end of their life. So I help out with the team that works at Trillium Health Partners Mississauga site, their palliative care team as well. In the community, when patients or individuals are very near to the end of their life, so usually in their last weeks to maybe last month or two, oftentimes they'll choose hospice care. So hospice is very different than hospital. It's more of a home setting. There's only 10 beds in the Dorothy Ley Hospice, which is the facility that I work in. And it's very much meant to be a home environment where loved ones are at the end of their life, not meant to be anything like hospital. So there's no machines, there's no monitoring of any sort. It's really just a place where people are kept comfortable, but there are nurses and personal support staff to help ensure that families can just be family members and not have to be the nurse and the caregiver and the cook and the cleaner and everything else if they were still at home. So that's kind of what my job looks like in terms of my palliative care roles. And as a physician, largely I'm in charge of kind of helping with the symptom management, but a lot of it goes beyond that in terms of also having pretty tough discussions about people's goals at the end of their life, things that they still wish to achieve. Helping connect some of the non-medical aspects of end of life, so some of the emotional, spiritual aspects as well, and making sure that people are kind of treated as a whole person at the end of their life rather than just a disease.
Yeah, so it does seem like palliative care is sort of like a heavy-handed occupation.
Mm-hmm.
What actually led you to your decision of becoming a palliative care physician?
I think in medicine, you get into it because you ideally want to help people and you have an interest in biological sciences. And I think if you ask most physicians, that's kind of what would have piqued most of our interest. Many people have personal stories that have led them into a career in medicine. But for me, it was largely the former. So wanting to become someone who would be able to help people and heal people and then combine that with a love of biological sciences. Medicine seemed like a good fit. But when you get into medicine, you realize that the fields are so diverse. And really, there's a field of medicine for every type of person. So you could become a physician that never actually sees patients, or you could become a physician that only cuts things out of people for the most part and doesn't have a lot of the social interaction. And I think as you go through your training, you learn what type of person you are and how a certain area of medicine kind of fits your personality and your skill set. And so that's, I think, how I fell into palliative care. It was something that I pursued after a residency in family medicine. So I knew that I wanted to do something where I was going to be able to get to know people form intimate relationships with them. And it went kind of beyond just kind of diagnosing and prescribing medication. And when I first was introduced to palliative care, I think it was just something inside of me that made me feel like this is a very rewarding profession, and something that is not highlighted very much in medicine, because we often think as medicine as treating illnesses and getting people better and fixed, but that's not always possible. And death is something that all of us will have to encounter in our lives, probably more than once, but personally, only once. But having an ability to enter someone's life at that point is really something special and rewarding. And so for me, that was the area of medicine that made me feel like I get up every morning. I don't feel dread going to my job. Every day is different. Every family is different. I feel privileged to be able to be a part of people's lives at that point in their lives and make the transition from being healthier to losing a lot of their independence, and then eventually passing away, and supporting both the individual and their family members to be the most rewarding aspect of medicine for me. And that's why I chose that.
Yeah, I think it's wonderful that you have such a passion for an important kind of niche healthcare role. But to address the elephant in the room, how, if at all, has your role as a medical professional changed since the outbreak?
It's changed quite drastically initially, I would say. So at first, when the first wave hit, we were largely not able to, but strongly advised against going into people's homes. So as you can imagine, when you're dealing with people who are dying or facing very difficult challenges in their lives, and then you're trying to provide care over Zoom or over other virtual means, it really changes the dynamic of the relationship. So that was really challenging, and still is very challenging for cases where we're trying to do a lot of the medicine virtually. It does take away a little bit of that personal piece that you really need when you're providing end-of-life care. So that was really difficult. And then, of course, when we are going into the homes and when we are bringing patients to hospice, that also changed quite drastically. So now, I have to wear a lot of PPE, whereas before I wasn't. And so now I'm behind a mask, and it's a lot harder for people who are already quite sick and maybe not as cognitively well as they previously had been. And now you're coming in masked and shielded, and you have gowns and gloves on. It's a much scarier experience for people. So it also changes the dynamic a little bit as well. And then, of course, similar to in hospital, in hospice, especially initially, there were quite strict visitor restrictions. So you can imagine having your loved one coming into a place where they're going to be for their final days or weeks, and only being allowed to see one other person from their family, right? And other family members have to either be visiting them through a window or over Zoom. And it was tough. We've loosened some of those restrictions now, so the visitor policy is a little bit more lenient as the pandemic has gone on. But certainly in those first few weeks and months, these were really significant challenges and made it a lot harder to do what we do well.
Yeah, so given these kind of increased responsibilities and regulations, especially when the outbreak first happened and these regulations were first implemented, did you feel that you were prepared as an individual to tackle those challenges at the time?
Yes and no. I think your training in medicine makes you learn how to deal with challenges as they come, because medicine is such an ever-changing field, and a lot of the people that are drawn to medicine tend to be kind of used to some of those challenges, and I would say for the most part we're pretty resilient people overall, but that resiliency only lasts so long, right? And all of us are human, and we are all susceptible to burnout, which I've seen a lot of with my colleagues and myself. Um, and I think, virtual medicine is new for all of us. That I don't think there are many physicians who had been practicing largely virtual medicine prior to the pandemic. So that's something that now all of a sudden we're trying to learn how to give medical care virtually, whether that be via video or a lot of times even just a telephone call, which is even more challenging. Not only that, a lot of us are involved in teaching as well, right? And so I teach first year medical students clinical skills. So you can imagine if you're learning how to take a blood pressure or how to examine somebody's belly, how do you teach that over Zoom? It is very difficult, and it's really changed the landscape of how we practice. And though I think in general we adapt well to change as best as we can, nobody could have ever been prepared fully for the changes that we saw over the past year.
Yeah, I actually did want to touch on that. You mentioned that you also help teach several first-year medical students in their clinical skills course. I
Mhm.
was wondering how you kind of navigate the environment of the world right now to try and still provide them the education that they need, especially given all the circumstances.
Yeah, it's really difficult. I mean, we're kind of put into specific teaching roles through the university. So while we do have some leeway in terms of what we can do, the university itself has kind of created a program that they felt would have been as best as it could be delivered virtually. But as you can imagine, if you're learning how to be a doctor, you need to be able to see, touch, feel, smell patients, right? You need to use your senses. And that's this course, right? It's clinical skills. It's learning how to be a doctor on the ground. And so teaching that when you only have the ability to kind of talk and listen, it takes away a lot of those other senses. And it takes away a lot of the other, even nonverbal cues that you have to kind of learn and develop over time to read patients, because a lot of times it isn't just what they say, right? And so to be able to teach that over Zoom is very challenging, but we're doing the best we can. Like we're using standardized patients, which are like actors that come in and they will interview with the students. We're trying to use videos as much as possible, but at the end of the day, they're not going to be as well prepared as if they were in class. So it's going to be a learning curve for them once we do get back to in person. And it certainly has been challenging as a teacher as well.
Yeah, so I'm also aware that you work at a long-term care home, and
Mhm.
unfortunately, it has proven to be that long-term care homes have become kind of a hotspot for COVID outbreaks because they are they hold some of the most vulnerable populations. How exactly have you tried to continue to provide care to long-term care homes, considering how at-risk individuals in those homes are?
So I actually joined a long-term care home after the first wave. So what happened was a lot of the long-term care homes, as you mentioned, were affected, and a lot of patients unfortunately contracted COVID and passed away. And because of that, it created an environment where we had to take a step back and look at how care is being provided in long-term care homes. And so there were a lot of changes that happened at the administrative levels and as well as the staffing levels at long-term care. And so I joined after that first wave, prior to residents getting vaccinated, however. And it's tough. I mean, you have to imagine people that live in long-term care are vulnerable. A lot of them have cognitive challenges. Many of them have physical challenges. Many have both cognitive and physical challenges. A lot of them are completely isolated because they're not able to see their family. And then you can't explain to them in a lot of cases. Why? Because they don't have the capacity to understand what's going on. And so you're trying to confine these people to a room, for this is going on, has been going on for months, right? And so trying to provide care has become very challenging, because normally in long-term care, that's their home. They would be engaging in activities. You would be getting them up and doing exercises with them, doing, you know, group activities, puzzles, having shared meals together, and all of that was eliminated. And so a lot of the medical issues then became, they were exaggerated. So behaviors became worse, depression and mood disorders became worse. It's been really tough, and we're only looking kind of at the end of the tunnel now. We're not there, but finally, you know, we're out of an outbreak. Residents have been vaccinated, and I think we can see the light, and hopefully bring people back to where they were. But it's certainly taken its toll on the individuals who live there, and the staff as well. I can speak to the fact that the nurses who lived through that first wave are severely affected. I mean, they saw a third to 50% of their residents die. They died alone, and a lot of them died without, you know, I do palliative care. A lot of them died without good palliative care because there just weren't the resources to provide it to the patients. So symptom management, the ability to provide the spiritual care, the emotional piece, the family piece, that was all taken away.
Yeah, so I can definitely see it being very difficult to try and connect with patients, especially when everything has become virtualized and you still want to provide that degree of care that you can't really do anymore. How has the healthcare industry, if at all, kind of tried to adapt to the situation to try and provide the level of healthcare that maybe these patients need, given the circumstances?
Well, I think putting more money into the virtual medicine has been what the government has done. So they've basically allowed physicians to provide virtual care and pay us for it. That's not to say that it's replacing in-person care, but it certainly allows things to be a lot easier when the staff are compensated for this alternate model of providing care. What I've seen in a lot of institutions, so both the hospital that I work at and the hospice, is that there's been a huge, donations of tech for patients and families. So normally, I don't know if you've been in many hospitals in Ontario, but we're pretty behind the times when it comes to tech compared to other industries in Canada. And I think that's largely because we're a publicly funded system and we just don't have the resources. But because of this, we've been able to get companies to, for instance, in hospice, a company donated, I think, 20 tablets, so that we had, each individual was able to have their own tablet in their room so that they could connect with their loved ones outside the home. And we've been able to use some of those tablets going into the community as well, because a lot of the programming that we would do in hospice, we would provide volunteer supports for patients. Just a lot of people are at home and isolated, and they would have somebody come in and check on them. That's not able to be done during COVID, but we tried to at least have it done in a virtual way. So if we had a tablet that we could bring to the house, we can connect the patient with a volunteer or a social worker or somebody who could chat with them once a week or so. And the same in the hospitals. So a lot of tablets were provided on the units for patients to have in their rooms and be able to not just talk on the phone with their family, but physically see their family, right? Because it does make a difference. And those were kind of the largest things that I saw change-wise in order to try and maintain as much of a semblance of normalcy as possible.
Yeah, so working on the front line, I'm certain you, along with your coworkers, friends, and even your family, have seen much of the pandemic through a lens that many of us aren't aware of. And if you don't mind, could you describe how you might have been kind of personally impacted by the situation, by the pandemic?
Yeah, I think it goes back to my experiences, especially in palliative care, right? And seeing people die alone. Um, Normally, you'd walk into the hospital and it would be bustling with people, whether it's the staff, the nurses, the cleaners, volunteers, the family members, and it was just full and full of, energy. And at the start of the pandemic, it was honestly like a ghost town. So I'd walk into the hospital on a Saturday and I hardly saw anybody. Everybody was so afraid to be in any kind of communal area. Obviously, no family members were allowed to be around, any non essential staff. So all the volunteers were gone. So now you no longer have people, bringing patients water and just sitting and chatting with people and providing some companionship in a time when they're kind of already isolated. Being in hospital at the best of times is never great, but now you add this layer of like it was like a ghost town, like I said, just quiet, um, and then if you think about the people who are really sick and are now like close to or nearing the end of life in that situation, it was devastating. It was really devastating because it's already a very emotional and sad time for people, and now they're seeing and saying goodbye to loved ones on tablets or through windows, and they're not necessarily having all of that love of people around them like you would in a non-pandemic situation. And so for me, that hit me the hardest, and that was the most challenging aspect, and still is. It is better, but it's still not where it was. So that's still a very difficult thing to see my patients and other people have to go through.
And so, as a registered physician, what do you kind of see the future of the health industry looking like? And what do you think it'll look like once the dust settles after the pandemic?
I think we're going to see more of a combination of virtual and in-person medicine, to be honest. I don't think it's going to go back to being fully in person, at least not for a long time. I think there's going to be a perpetual feeling that there may be looming another pandemic on the horizon just because of how much travel internationally we do and how easy it is to do that nowadays. And just simply the changing nature of viruses and bacteria that we have anyway, and how at any given time we could have a highly resistant organism that then becomes an epidemic or a pandemic, right? So I don't foresee us going back to 100% in-person care. I don't foresee us losing the PPE anytime soon either. So I think for a long time in the future, when you go to see your doctor, they're going to be wearing a mask. Normally, before the pandemic, we'd wear a mask if you were coming in because you had a cough, or if I felt a little bit, like I had a sore throat, or if I was doing some kind of invasive procedure. But day to day, I wouldn't be wearing a mask to see you, right? And I don't think that's going to go away anytime soon. So I think that's going to become much more of the norm in the future of medicine as well. Probably also a little bit of more attention paid to just general sanitation practices as well, and probably not having ward rooms in hospitals with perhaps 4 or 6 people in them anymore. And I think there's going to be a big change in terms of trying to look at the infection prevention and control, and the layouts of hospitals will probably change, as well as ventilation, et cetera.
Yeah, and just as a final question, I guess specifically towards an audience of mostly high schoolers, is there anything you'd like to say about kind of what it's like to work on the front line?
Yeah, I mean, we're privileged in many ways because we get to see people at the best and the worst times of their lives, right? But when you throw a pandemic in, it's very challenging, and it's not just for physicians. It's the nurses, it's the personal care workers, the cleaners, the people working in the kitchen. It's it's a daily grind now, and there's not a lot of room for breathing, unfortunately. And it's because you have to quarantine for 2 weeks if you have a symptom, or if you get COVID yourself, or you're not allowed to work in multiple facilities. And so we're very stretched thin, and it's a very different feeling working on the front lines now. And I think a lot of people are burnt out. And so um, people are a lot quicker to react to things that maybe they wouldn't have reacted to a year ago. And so I think the important thing is just to remember that we're all in it together, and we all just have to have compassion for one another at the end of the day, because, if one of us is having a worse day than others, it's not going to help anybody to be upset with them, or to be frustrated, because we're all going to have those moments, and we are. And this is still going to go on for likely at least a few more months.
Dr. Salvo, I truly appreciate your time. Thank you for coming on to the podcast.
You're welcome, Albert.